the first question, a patient with chronic kidney disease has the following labs: BUN 40, creatinine 3.2, sodium 138, potassium 6.0. Which intervention takes highest priority? A, restrict oral protein intake, administer Caxolate. B, C, start loop diuretic, or D, give IV normal saline bolus. Choose your answer, save your patient. Hey Arlene, welcome. Carousel, how are you doing? Welcome, welcome, welcome. Reggae Roots, welcome. All right. Renee says she never study. Now we're studying. All right. So I see B here, administer Caxolate. Okay. All right. We'll move on to that one definitely. All right. So we know that this patient is hyperkalemic based on the lab value here. All right. So we'll go ahead and administer Caxolate. Potassium 6.0 is life-threatening. Immediate measures to lower potassium, including your Caxolate, insulin, glucose, calcium, if EKG changes are there, usually takes priority. All right. And that's the cocktail. This is the cocktail for your hyperkalemic patients. All right. I'm trying to make sure I don't miss any. A patient with nephrotic syndrome is most at risk for A, hypocalcemia, B, hypercoagulability, C, metabolic acidosis, alkalosis, or D, hypernatremia. So a patient with nephrotic syndrome is most at risk for let's see, D, C, Sheila, welcome. All right, C, metabolic alkalosis. Let's see, hypernatremia. All right, C, C, D. Okay. All right. We have here hypercoagulability. All right. Loss of the antithrombin 3 and other factors in the urine increases the thrombus risk in nephrotic syndrome. All right. Well, let's go on to, okay. What is the best indicator of renal function? A, BUN. B, serum albumin. C, urine specific gravity, or D, creatinine. What's the best indicator of renal function? A, BUN. B, serum albumin. C, urine specific gravity, or D, creatinine. Hi, official Yayu. Welcome, 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 welcome. Let's see, creatinine. What are we saying here? All right, so D, creatinine. Okay. Serum creatinine reflects glomerular filtration. It's a more specific marker of renal function and BUN. All right, BUN usually will indicate if you're having, like, dehydration. That's usually pretty good with dehydration. Serum albumin usually indicates what? If you have like an elevation or you have low albumin, what usually that indicates? Okay, so protein. Yeah, so usually when you lose a lot of protein, you tend to have your low albumin levels. All right. And urine specific gravity, what usually that indicates? So basically the concentration of the urine, basically. All right. What's your normal value for your specific gravity? Yes, Falasad. What's a normal specific gravity value? Or the range? What's the range for your urine specific gravity? Avalon, thank you for following. Hi, Druville. How are you? Okay, yeah. So some persons remember it as 10, 10, 30. All right, so 10:05, 10:05, 30, or 10:05, 10:30. Okay, 1.0. So yeah. All right, so the 1.002 to 1.030. All right, but just make sure you look up which one NCLEX is using. All right. And we talk about the creatinine here. All righty. A patient with acute glomerulonephritis develops periorbital edema and Coca-Cola colored urine. The nurse recognizes this is caused by A, tubular necrosis, B, renal artery stenosis, C, immune complex deposition in glomeruli, D, excess ADH release. So a patient with acute glomerulonephritis develops periorbital edema and cola-colored urine. The nurse recognized this is caused by A, tubular necrosis, B, renal artery stenosis, C, immune complex deposition in the glomeruli, or D, excess ADH release. No, I'm not Dravili. All right, I'm a nurse. All right, so we have CC, immune complex deposition in the glomeruli. All right. So post-infectious glomerulonephritis involves immune complexes causing inflammation, hematuria, and edema. All right. So usually when you have the periorbital edema and cola-colored urine, it is caused by the immune complex deposition in the glomeruli. All right. Which medication should be held before administration of IV contrast to protect kidneys? A, metformin, B, lisinopril, C, furosemide, D, warfarin. So which medication should be held before administration of IV contrast to protect kidneys? A, metformin, B, lisinopril, C, furosemide, or D, warfarin? All right, let's see. A, metformin. Okay. All right. Why? Why you want to hold your metformin? Can cause lactic acidosis, Sancha is saying. Nice. All right. All right. I see one person says C, furosemide. Rabi says C. Emily Rose says B. All right. So lisinopril actually helps with protecting the kidneys. All right. So don't get it confused. Just make sure you're looking at the words. So which one should be held before administering IV contrast to protect the kidneys? All right. Thank you for the heart, Abby. All right. So which one will you hold? All right. It's going to be your metformin. It is held to prevent lactic acidosis if contrast induces renal impairment. All right. So A is definitely the one you're going to be holding. Remember to talk to your diabetic patients and let them know, hey, you're going to do your test tomorrow. Do not take this medication. All right. What kind of drug is lisinopril? Welcome, welcome. How are you guys doing? What drug is ACE inhibitor? Definitely. All right. And we know that furosemide is your loop diuretic. And warfarin is what kind of drug? Anticoagulant. All right. Nice. A client with acute tubular necrosis is in oliguric phase. All right. Which nursing action is most appropriate? A, monitor fluid intake and daily weights. B, encourage high protein diet. C, administer magnesium supplements routinely. Or D, increase potassium in diet. So a client with acute tubular necrosis is in the oliguric phase. Which nursing action is most appropriate? A, monitor intake and daily weights. B, encourage high protein diet. C, administer magnesium. And D, increase potassium in the diet. Cue the nurse, not a problem. All right. D, increase potassium. I see A, monitor fluid. How are you doing? All right. So our answer is definitely going to be to monitor fluid intake and daily weights. All right. When the patient is in the oliguric phase, what's going on here? What's going on in the oliguric phase? What's oliguria? Urine is usually less than 30 mils. Okay, so low urine output, they aren't urinating. Okay. So just a small amount. Leading ovation says they're unable to urinate. I wouldn't say unable to urinate, it's just that their urine amount is just small. Alright. So they're not making much urine. Alright, so this patient is in the oliguric phase. You want to definitely make sure you're monitoring. Yes, usually end-stage renal. So monitor their fluid intake and their daily weights, alright? Because they're going to be at risk for fluid overload. So you want to make sure you're monitoring that, alright? Would you increase potassium in this patient's diet? Would you increase potassium in this patient's diet? All right, definitely not. All right, increasing potassium is just gonna run the risk of getting this patient, you know, in any form of arrhythmia. So you want this patient to get dialysis done. All right,
okay.
So
I found this on the web. For potassium is gonna run the risk.
No, I tell you about these Siri. Anyways, all right. So definitely no increase in potassium. All right. What about high protein diet? Is it something that you recommend for this patient? Artist Dudley. Enjoy your evening. Thank you. That's not necessary? No. Okay. Notice you already did. Definitely. All right. Not a problem. Cue the nurse. All right. Well, let's go down to this one here. All right. Hold on 1 minute. Just get this thing sorted out. Uh-oh. Uh-oh. I think you guys see it already. All right. Go ahead. I'll try and get this fixed. Which findings suggest pre-renal acute kidney injury? All right. A, muddy brown cast on urinalysis. Fractional excretion of sodium. C, elevated urine sodium. Or D, oliguria with hyperkalemia only. cause filter problem. See A, acute sudden onset. All right. Let's see D, oliguria. Which finding suggests pre-renal acute kidney injury? All right. A or D? I want to say D. All right, let's go down. So who had said B? Let's see, Ruby had said B. Few persons had said A. All right. So Ruby. All right, let's just look up so the low fractional excretion of sodium indicates kidney conserving sodium due to decreased perfusion, and that's happening in the pre-renal phase. All right, so we need to look at the pre-renal, intra-renal, and what's the other one? And the post-renal, definitely. So all other answers are long-term for your kidney injury. All right. So look at the different types of kidney injury, and then from there you'll be able to tell what is happening. So oliguria, this is where they're not making much urine. You have the elevation in the sodium. All right. Muddy brown cast on urinalysis. All right. So all of those are later on. All right. A patient with hyperkalemia exhibit peak T waves on EKG. Immediate medication to stabilize cardiac membrane is A, IV calcium gluconate, B, IV insulin and dextrose, C, nebulized beta agonist, or D, oral potassium binder. All right, A. All right, definitely A. All right. So we have A, IV calcium gluconate. All right. What are we? Oh, well, we already know that we're treating hyperkalemia here. And EKG finding is your peak T wave. All right. Insulin also lowers your potassium, definitely. All right, but you're looking at the question here. Which of these medications, because all of these are what you'll be using to treat your hyperkalemia. Which of the medication you're given is going to stabilize your cardiac membranes, all right? The one that is focused on protecting the heart is your calcium gluconate. Your IV insulin and dextrose is going to work on your potassium, getting those yes. All right. They're just general questions. We're just studying broadly that, girl. All right. It will still help you for your NCLEX. All right. And then from there. So we talk about. All right. So your IV calcium gluconate. Calcium stabilizes myocardium quickly. Insulin plus glucose shifts potassium intracellularly, but does not stabilize your membrane. All right. So the calcium gluconate doesn't lower potassium, it just stabilizes. Yes. All right. A patient with kidney stone complains of severe flank pain. Which instruction is appropriate? A, take high oxalate diet to help pass the stone. B, restrict fluids to 500 mils per day. C, avoid analgesics until the stone passes. Or D, strain all urine. So a patient with kidney stone complains of severe flank pain. Which instruction is appropriate? A, take high oxalate diet to help pass the stone. B, restrict fluids to 500 mils. C, avoid analgesics until stone passes. Or D, strain all urine. All right, so we have D, strain the urine. So we are trying to find out what kind of stone this patient is passing. All right, so you want to capture all the stone, and then from there, restricting fluid is just going to worsen this patient's, situation with the flank stone, the flank pain. Okay, you want to encourage a lot of fluids, push fluid to get those stones out. Ioxalate diet, you don't want to encourage that. That is not going to help with passing the stone. All right. Avoid analgesics. Definitely these patients need analgesics for their kidney stones. All right. So yes. So ioxalate diet is going to increase your chance of getting additional stones. All right. So it's important for us to have them strain, find the urine. Sometimes they can get it tested to see what the stone is actually made up of, and then from there they can alter, make changes to their diet. All right. All right. A patient with chronic renal failure reports pruritus and skin excoriations. The nurse should A, increase dietary protein, B, encourage hot showers to relieve itching, C, apply emollients and keep nails short, D, recommend high phosphate diet. So you have a patient here that is in chronic renal failure. They're having pruritus and skin excoriation. What are you going to be doing? Ahmad says D, recommend high phosphate diet. Everyone else is saying C, apply emollients and keep nails short. What is happening with this patient? Why the patient is having the pruritus? C, maintain skin integrity. Okay. So the patient is having the irritation. Why is this patient having the skin irritation? The patient is uremic. Yes, the patient is in chronic renal failure, but why is the patient having the itching? Because of the buildup of that uric acid. Bile buildup. All right. So you want to encourage them to apply emollients and keep the nails short. Uremic pruritus is relieved by skincare and avoiding heat, which worsens itching. All right. C. Which acid-base disturbance is commonly seen in diabetic ketoacidosis and can worsen with renal failure? A, metabolic alkalosis, B, respiratory alkalosis, C, respiratory acidosis with an anion gap, or D, metabolic acidosis with an anion gap. Kiara says D, Carousel, DD, Leading Innovation says metabolic alkalosis. All right, so remember the buildup of the acid here, it's gonna be either acidosis here or acidosis here. Then try to remember which system is actually being affected. All right, so you're gonna have your metabolic acidosis with an anion gap. All right, so DKA causes increased acid, the ketones. All right, renal failure impairs acid excretion. So always remember that your DKA patients are always acidotic, metabolic acidosis. All right. All right. A patient with polycystic kidney disease is most likely to have which family history? A mother with the same disease, a father with type 1 diabetes only, C, no family history is required, or a D, sibling with hypothyroidism. So a patient with polycystic kidney disease is most likely to have which family history? A, a mother with the same disease, B, a father with type 1 diabetes only, C, no family history is required, or D, sibling with hypothyroidism. Kiara is saying A with her face covered and a question mark. Renaissance says C. Vusa says C. Okay. All right. The mother with the same disease. Findlay says A. Carr says Maiden of Malice says I'm thinking A or C. All right. So A. The mother with the same. So it is usually autosomal dominant. A positive family history is very common. All right. So this is your polycystic kidney disease patient. So the mother usually is diagnosed with the same history. A nurse reviews the urinalysis and the results showed protein 3 plus, red blood cell count is present, white blood cell count is absent. This pattern most likely indicates A, upper urinary tract infection, B, glomerular disease, C, dehydration, or D, diabetes insipidus. So you're looking at the urinalysis and you see 3 plus protein, red blood cells present, white blood cell count is absent. What are you thinking? So I see B, B, D, glomerulonephritis, diabetes insipidus. B, C, dehydration. Okay. All right. So you have 3 plus protein. You have white blood cell count that is absent. Red blood cell count is present. Think about the pathophysiology here of each of these. All right. So you have a glomerular disease, should be C because of absent of white blood cell. Should be C because of the absence of white blood cell. Do you have red blood cells present in when your patients are dehydrated all the time? Unless something else is going on. All right, so glomerular disease. So heavy proteinuria and hematuria with pyuria usually suggests glomerular pathology. All right. So you have 3 plus protein, you have red blood cell present, no white blood cells. So you're not thinking about upper respiratory infection, not an upper respiratory, urinary tract infection. All right, what are you looking for in terms of for the urine for a diabetes insipidus patient? What are probably some of the findings you'll have for your urine for that patient? Glucose, okay. All right, I see Arlene says ketone, glucose. Do you have ketones in your diabetes insipidus patients? Okay, decrease specific gravity. Okay, so you're not gonna find any ketones in your urine. All right. So your specific gravity is gonna be what you're gonna be looking at. You're looking at your specific gravity. You might have, the urine output is gonna be a lot, but they're not gonna have any protein. All right, they're not gonna have any protein, and this shows that this patient has 3 plus protein. All right, so you're not gonna find any protein in this patient. For dehydration, the specific gravity is gonna be elevated. All right, you're gonna have high specific gravity for this patient. Unless there's something else going on, you might see like your red blood cells present. All right, they lack ADH, maybe. Okay. All right, and then for your upper urinary tract infection, definitely, if it's a UTI, there is gonna be some white blood cell count that is present. All right, and you might have your little red blood cell as well. All right. So a patient with end-stage renal disease reports nausea, confusion, and metallic taste. The lab shows potassium of 7.2 milliequivalent per liters. The nurse anticipates. All right, I think we keep on seeing these questions. All right, so the lab shows your 7.2 for your potassium. The nurse anticipates A, immediate preparation for dialysis, B, administration of oral potassium supplements, C, restriction of protein intake only, or D, start IV normal saline. I see 1B, administration of oral potassium supplements. Was it a mistake, Car? Okay. All right, definitely you want to get this patient ready for dialysis because this potassium is too high. All right, this patient is at risk for what? What is this patient at risk for? Cardiac arrhythmias, definitely, definitely. All right, so you want to get this patient over to dialysis. All right, so severe hyperkalemia and uremic symptoms need urgent dialysis if medical measures are insufficient. All right, remember this patient is in end-stage renal disease. You want to go ahead and start any normal saline on this patient, all right? Because you're going to put this patient in fluid overload. All right, you definitely want to restrict your protein intake, but because of this answer with the only there, it's not an, you're not going to choose that for your exam. Administration of oral potassium, you're like, sending your patient 6 feet under. All right, so you're not gonna give any potassium to this patient. They have already too much there. All right, so the normal range is gonna be your 3.5 to 5 in terms of your potassium level. All right, and make sure you get this patient on your cardiac monitor on the entire 9 yards. For a patient receiving peritoneal dialysis, which signs suggest possible peritonitis? So a patient receiving peritoneal dialysis, which signs suggest possible peritonitis? What is peritonitis, by the way? What is peritonitis? Infection of the head, the eyes, the knee. Let's see, if 2GB says bleeding, nice. Inflammation of the peritoneal cavity, peritoneal, okay, nice. Peritoneum infection, nice. All right, so for the patient receiving peritoneal dialysis, which finding is suggestive of possible peritonitis? A, cloudy diastolate effluent. B, decreased ultrafiltration volume. C, mild leg cramping. Or D, clear outflow with high volume. A. All right. Cloudy. All right. So which of them suggests possible peritonitis? Cloudy effluent indicates infection, inflammation, peritonitis. This needs evaluation and antibiotics. All right. Is this like a medical emergency? What? Is it like something we can just watch and wait? How would you plan for this patient? What's the next step for this patient? What would you be doing for this patient? Surgery, okay. You can monitor after antibiotics. Okay. Start antibiotics, emergency surgery. Okay. All right. So especially if their abdomen is like, firm, then definitely you want to prep them for surgery. All right. Emergency surgery. Nice. So a 24-hour urine collection requires the patient to A, collect only night urine, B, discard first morning urine and collect all urine for the next 24 hours, C, store the container at room temperature only, D, void into the toilet for measurement. I want go on up here, so. I want go on here, so Jamaican. What's up? Welcome, 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 everyone. Can't manage you. I cannot. All right, so B, okay, discard the first morning urine and collect all urine for the next 24 hours. Why are we discarding the first urine? Why are you discarding the first urine? Top diluted, contaminated. Okay. All right. So discard the first morning urine and collect all urine for the next 24 hours. All right. So that's the standard. You want to make sure you're getting a clean catch throughout the day. So the first part is usually like contaminated, and then from there you go ahead and do that. All right. So you discard first morning urine and then collect all the urine for the next 24 hours. You want to make sure you keep the container stored at room temperature. All right. Void into toilet for measurement. There's no way that is possible. All right. Which diuretic here is potassium sparing? A, furosemide, B, hydrochlorothiazide, C, spironolactone, or D, mannitol? All right. I see C. All right, your spironolactone. Okay. What is your mannitol? What class of drug is mannitol? Osmotic, yes, you use it for, okay, ICP, medication. Okay, nice. Osmotic diuretic, yes. Edema for your increased intracranial pressure. All right, nice. And we already know furosemide. And your furosemide is your loop diuretic, nice. Yes, your loop diuretic and hydrochlorothiazide. Your hydrochlorothiazide is thiazide diuretic, nice. It's spiral, okay. Thiazide diuretic, yes. All right, so which of them is potassium sparing? All right, your spironolactone. It is an aldosterone antagonist and it spares potassium. All right, so this patient is going to be at risk for what? What you have to keep an eye on for this patient? High potassium, yes. So high potassium, hypotension, arrhythmias, definitely keep an eye on the patient for your elevated potassium. All right, nice. All righty. So patient on ACE inhibitor, welcome everyone. Oh, I see 181 persons here. Welcome, Wagwan. Just in case you're from Jamaica. You know, I'm Stacy here. So thank you guys for tuning in. Just go ahead and tap up the screen. That would be nice. And follow. All right, we do our live streams on Tuesdays. We're trying to do it like every day. Not Monday to Friday, but you know, Monday to Thursday at 7 p.m. Central Standard Time. So tune in where we can interact and just study together. All right. Oops, Wagwan. I'm here. All right. So thank you guys. All right. So patient on ACE inhibitor reports cough. The nurse recognized this as a expected opioid side effect. B, common ACE inhibitor adverse effect. C, sign of bronchospasm requiring intubation. Or D, irrelevant to the medication. So a patient on ACE inhibitor reports a cough. The nurse recognizes this as B, common ACE inhibitor adverse effect. All right. So this patient is having an effect to it. What's the next alternate medication you can think of that this patient can be on? So it's a kind of common side effect. Common side effect, adverse effect. So definitely you can get them on your ARBs. All right. So if this patient is showing any sign of bronchospasm, what are you thinking about that is going on with this patient because of the ACE inhibitor? What life-threatening condition could be going on because of this ACE inhibitor here? They could be having angioedema, definitely. All right. Relax smooth muscle. This smooth muscle is not relaxed, Wesley. All right, so this smooth muscle here, bronchospasm. No, that's not relaxed. All right. Drooling, life threatening, definitely. All right, no problem. You're gonna have like bronchoconstriction taking place here, or bronchospasm. All right. So definitely you'd consider an alternative if it is severe. So the dry cough is known for your ACE inhibitor side effect, and it might require switching to one of your ARBs. All right, if they're having that side effect. So you try to taper them off, and then from there switch them over to your ARB. You stop them abruptly if they develop any, like, you know, angioedema or anything like that. Losartan, definitely. All right. Which electrolyte imbalance is most associated with acute kidney injury? A, hypokalemia, B, hyperkalemia, C, hypophosphatemia, or D, hypomagnesemia? So A, B, B. Okay. All right. B, D. Okay. All right. So which of the electrolyte imbalance is associated? You have your hyperkalemia. All right. So impaired renal excretion often leads to your hyperkalemia in your patients here. All right. And you're expecting what kind of EKG findings again on your hyperkalemic patients? Chronic kidney disease is hypokalemia. Acute kidney injury is hyperkalemia. Hi, Jay. Thank you. Thank you. You're looking at your PT waves. All right. Yes, you can have arrhythmias because of that, Wesley. Not so sure exactly if you'll have AFib, but you'll have an arrhythmia if it is too elevated. All right. All right. In terms of for the hypomagnesemia, what side effects you're expecting for this patient? Or signs and symptoms? Muscle weakness, tremors, yes. Danny, you come on this page with the same thing over here. Welcome to the page though. All right, just go ahead and top up the live in the meantime. That would be nice. Or share my live to 5 persons. All right, that would be nice. All right, yes. So your spasm, tremors, you know, arrhythmias, all of those. All right, and your hypokalemia will almost be like your same, you know, in terms of with your hyperkalemia there. All right, the same as hypocalcemia, lethargy, definitely. All right. A patient with nephrolithiasis has a stone composed of calcium oxalate. Which teaching is appropriate? So A, avoid all dairy products. B, increase oxalate intake to dissolve stones. C, take vitamin C supplements liberally. Or D, limit high oxalate foods like spinach and rhubarb. So a patient with nephrolithiasis has stone composed of calcium oxalate. Which teaching is appropriate? D. Limit high oxalate foods like spinach and rhubarb. Nice. Okay. All right. Because those will promote high oxalate foods can promote calcium oxalate stone formation. That's why it's very important when you have a patient with kidney stone, try to give them one of those little, you know, the little strain of the mesh to try and collect those stones, because you can get it tested, and then from there you'll be able to tell how to, you know, in terms of managing their diet, what they're supposed to be avoiding, because this is what their stones are predominantly made up of. All right. All right. Which of the following is a complication of bladder outlet obstruction? So which of the following is a complication of bladder outlet obstruction? A, hydronephrosis, B, glomerulonephritis, C, nephrotic syndrome, or D, interstitial nephritis. Let's see, A, hydronephrosis, A, nice. Okay. All right, so you're thinking of a blockage at the outlet there. All right, so you have your hydronephrosis. Obstruction causes urine backup and dilation of renal, pelvis, or the collecting system. That's in hydronephrosis. All right, so which is a complication of bladder outlet obstruction. That is your hydronephrosis here. All right, so anything that is preventing the urine from flowing properly. So sometimes you have persons with, like, you know, your BPH, any prostate problem, urethral strictures, things like those can cause problems with outlet. All right. It is a backup of fluid into the kidneys, though. Yes. Yes, Jess. The kidney swells. Alright. Let's go on to this one. A patient with renal artery stenosis may present with A, refractory hypertension and rising creatinine with ACE inhibitor use, B, bradycardia and hypoglycemia, C, hematuria and proteinuria only, D, hypernatremia and weight loss. So a patient with renal artery stenosis may present with A, refractory hypertension and rising creatinine with ACE inhibitor use, B, bradycardia and hypoglycemia, C, hematuria and proteinuria only, or D, hematuria, well, hypernatremia and weight loss, my bad. All right, I see C, Mansoor, welcome, welcome, A. All right, so the refractory hypertension and rising creatinine with ACE inhibitor use. All right, so the patient with renal artery stenosis may present with a refractory hypertension and rising creatinine with ACE inhibitor use. So renal artery stenosis causes renal vascular hypertension. ACE inhibitors can reduce glomerular filtration rate and raise the creatinine. All right. A nurse is teaching a patient about hemodialysis. All right. And a nurse teaching a patient about hemodialysis should include A, hemodialysis is performed daily at home without vascular access. B, hemodialysis removes protein stores only. C, blood pressure is not monitored during dialysis. D, a vascular access, AV fistula, should be protected. D, a vascular access should be protected. All right, D, nice. So it should include a vascular access, should be protected. Do we take blood from these AV fistulas? Do we take blood from these fistulas here? No, yeah, we don't do anything with these. All right, just make sure the dressing is looking good, clean and dry, and leave that fistula. All right. Blood pressure is not monitored during dialysis. True or false? You can take on the other arm. Yes. All right. So blood pressure is not monitored during dialysis. You have to keep a close eye because just remember you're taking fluid from this patient. So more than likely this patient is going to become hypotensive for a little bit. All right. So a lot of times they tend to become hypotensive because you just drain how much liter of fluids from them. All right. Hemodialysis removes protein stores only, not only protein stores, all right? Hemodialysis is performed daily at home without vascular access. False, all right? It's not usually performed at home. Which one of the dialysis is performed at home? Which dialysis is performed at home? PD. What's PD, Alexis? After we don't know what PD is. Don't know what PD is, you know. It's the stomach, peritoneal, noise. All right. So yes, the peritoneal dialysis is done at home. All right. Dialysis stomach. We have HHD. Okay. All right. So I think I saw something earlier. Hold on there. So you don't take it during even on the opposite arm. You take blood pressure, but you don't take blood pressure on the side that the patient has the fistula, or the side you don't take it on the side that the patient has the fistula. So the patient has, you know, two lower extremities you can use, and you can use the opposite side and get to your blood pressure checks. All right. So, but not on the side. You definitely need to be monitoring your blood pressure because, as I said, the patient is going to become hypotensive. All right. During dialysis, yes. All right. Papa. Hemodialysis. Okay. All right. So the vascular access should be protected. No blood pressure, no blood draws on that arm. All right. Protecting fistula prevents complications and ensures function. Oh yeah. So what are you expecting at the fistula side? When you're doing your assessment, what are you looking for in terms of at your side for your assessment? I think I saw someone said it earlier. Okay, thriller and brute. All right, Jay, welcome. Yes, feel for the brute here. Hear the brute. Yes, definitely you want to make sure you're checking. All right. And if you do feel for it and you hear it, what is that telling you? What does it tell you? Is that something good or is it something bad? It's something good. All right, you're supposed to be hearing your thrills. All right. If you don't hear it, then it's bad. All right, it means that there's probably some obstruction or something going on. But you want to make sure it's patent. All right. All right, nice. Yes, Claude Bear. Definitely you want to listen for that whooshing sound. Alright. And it always feels nice. You can feel it. You'll probably just go over there and drop asleep, rubbing it, palpating it, or touching it. Yeah, it has a nice little feeling. Alright. Which acid-base disturbance is commonly seen in renal tubular acidosis? And if you don't know the answer, always just use the process of elimination and go from there. All right. So, which Acid-base disturbance is commonly seen in tubular acidosis, in renal tubular acidosis. So we know definitely it's going to be what? One of the acidosis, because the answer already told us. The question already told us that it is acidosis. So renal acidosis, so put an X beside the alkalosis because that one is through the window. This one is through the wall. So we have respiratory acidosis and this metabolic acidosis that we have to think about. And if we know that it is renal, yes, so we're thinking along the line of your metabolic acidosis. All right, so look at the question and look for anything that will give you an answer. Metabolic is usually, or renal is usually metabolic. All right, so for this patient, you will have normal anion gap, metabolic acidosis. So right tubular acidosis causes failure to excrete your hydrogen ions or reabsorb your bicarbonate, leading to non-anion gap metabolic acidosis. So as I say, you have your renal tubular acidosis. So this patient is going to be acidotic, all right? And we know that with the kidneys, it's metabolic. And then from there, you know, you just use your process of elimination and try to answer the question, all right? Important to read carefully because I swore I saw metabolic acidosis. Oh my word. You think it's metabolic acidosis? No. So definitely look at the keywords because it's going to be some simple things, all right, that are going to be there. All right. So what's anion gap? So usually it's like a value. It's a value that they use to help with telling, like, you know, how bad your acidosis is. All right. So usually you look and do the calculation, and then based on that, you will be able to tell or determine the cause of a patient's like metabolic acidosis. All right. So just look it up. I think it's like you use your sodium, you use chloride, and what's the other one that they use? Your bicarb, the sodium bicarb, and your chloride to help with telling your anion gap. All right, so just look up that because that is very important. In what condition is the anion gap important in? Well, we know about, but in terms of with your acid base and with your, I'm not gonna say it, but anion gap is very, very important. A lot of times you'll hear the doctors be asking, what's the gap? What's the gap? Let's close the gap. DKA, definitely. All right. So you'll always hear them be saying, what's the gap? That's what they're talking about, the anion gap. All right. Sometimes the gap is not closed. You can go ahead and continue with your fluids and all. Your bicarbonate, yes. All right. So a patient with a UTI, urinary tract infection, complains of flank pain and fever. Which condition is likely? A, cystitis, B, pyelonephritis, C, nephrotic syndrome, D, urethritis. So a patient with UTI complains of flank pain and fever. Which condition is likely? A, cystitis, B, pyelonephritis, C, nephrotic syndrome, or D, urethritis. B, nice. Hi, Megan. Welcome. How are you doing? RN to CEO. What's up? All right. So definitely you're thinking about your pyelonephritis. All right. Your flank pain here. All right. So definitely your pyelonephritis. Flank pain plus fever indicates upper tract infection, pyelonephritis. All right. And this is your bladder infection, nephrotic syndrome, urethritis. For a patient on a renal diet, which food choice is best to limit potassium? All right. In other words, which one of the medication you're going to avoid or food you're going to avoid? A, banana, B, apple, C, orange juice, or D, baked potato. So for a client on a renal diet, which food is best to limit potassium? A, banana, B, apple, C, orange juice, or D, baked potato? All right, A. All right, banana, D. Apple a day. Apples are lower in potassium compared to bananas, orange juice, and potassium. All right. So for a patient on renal diet, which food choice is best? Is best to limit potassium. All right, your apples. All right, so you have your banana that is high in potassium, orange juice, and potatoes that are high in potassium. So definitely you wanna, this one I would have probably, yes, this one was a little bit tricky. So for a patient on renal diet, which food choice is best to limit potassium? All right, which one would you avoid? Oh no, still sounds weird, right? For a patient on renal diet, which food choice is best? Which food choice should you, well, all right, which food choice is best? When you say avoid, it would be, but banana, potatoes, and orange juice is high in potassium. So it should have read, for a patient on renal diet, which food choice is best to limit potassium? So it's gonna be apple. Which food choice is best? Choice is best to limit potassium. All right. Yes. So B for real. Very important to take time to read the question. So for a patient on renal diet, which food choice is best to limit potassium? Banana, apple, orange juice, or baked potato? All right. And then the other thing is, you see, if you're reading as well, sometimes slow down and make sure you're because if you realize that you know that potassium is high in potato and we know that it is in banana, go again and read over the question, because more than likely you're missing something, because they wouldn't be putting, you know, two of the same answer, you know, separately. All right, so just look at the question and then from there read it over, because bananas are high in potassium, potatoes are high in potassium, orange juice has potassium. The apple here is the one that is, you know, questionable. So if you're going to limit your potassium, the best one is going to be through your apple. All right. So definitely look at that. So apples are lower in potassium compared to bananas, orange juice, and potassium. All right. A patient with acute kidney injury has metabolic acidosis. All right, you come back here again. Metabolic acidosis, kidney injury. Which lab reflects compensation? So how do you know that a patient is compensating? What lab are you looking at? Is it going to be high or low? Is it the A, low bicarbonate, B, I, partial CO2, C, low partial CO2, or D, high bicarbonate? Which of the lab will reflect that this patient is compensating? Let's see, D, high bicarb, B, D. All right, and I see C, and this person laughing, or J laughing. All right. So if the patient is compensating and this patient has acute kidney injury, is it going to be a metabolic? Is it going to be a respiratory problem or a kidney problem for the compensation? All right, so just remember, if you have the kidneys that are being affected, the compensatory, what is going to be happening for metabolic acidosis? The bicarbonate goes up. So respiratory, metabolic, yes. All right, if you have the respiratory, the compensatory system is going to be your kidneys. All right, so just always think about the opposite. All right, so the patient with acute kidney injury has metabolic acidosis. Which lab reflects compensation? That is going to be your low PaCO2, all right, because this patient is going to be hyperventilating. So the patient is going to have respiratory respiratory compensation going on. All right. If it was the lungs that was going on, then you'd have the patient having the kidneys that is compensating. All right. So C, the respiratory system compensates for metabolic acidosis by blowing off your CO2. All right. Oh, let me fix this up. Ooh. All right, nice. Sorry, but we're at this question. We're gonna be at question 28. All right. Which medication increases urine output by raising the osmotic pressure in renal tubules? A, hydrochlorothiazide, B, mannitol, spironolactone, C, or D, furosemide. I think we already did. All right, Selena, welcome, welcome. All right. Remember, look at the keywords. I see a few persons saying D, 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 D. Furosemide. What kind of drug is furosemide? I'm gonna stop following one another. Somebody change it. Paul, thank you. All right. Okay. So let me see. Nobody. Oh, Izzy, welcome to the club. Change up the game. Yes, Izzy. Angel, Tasha, noise. All right. So remember, which medication increases renal output by raising osmotic pressure in the renal tubules? All right. Your mannitol. Your osmotic pressure here. All right. All right, so remember that. So try and remember the medication. Look at it and see, okay, what class of medication? Look at the class of medication, and they're all diuretics, yes. Look at the medications, and then from there, all of them are diuretics, all right? But you need to find out which one is going to be working where, all right? So you're going to have your mannitol that is going to increase your osmotic pressure, all right, in your renal tubules, all right? Nice. G, nice. Well, hang out with us over here. Make sure you go ahead and follow the page, all right? And you'll be fine. You definitely need Jesus, you know, but you'll be fine. All right. So mannitol is just the only osmotic medication here, the one that is osmotic in nature here. All right. So mannitol is an osmotic diuretic that increases urine osmolarity and diuresis. All right, so as I say, if you realize that all the answers are the same in terms of they're all blood pressure medications, they're all diuretics, read over the question and look for something different in the question, and then from there, all right? So that's all. The questions, I don't know, I guess the screen is like nervous. I don't know why. Let me see. I don't know why it's like that. It's just weird. Oh, I think probably because of my what do you call this thing here? Gimbal, I think, probably. Let me see if I fix it. And probably the wind from the fan. Anyways, guys, go ahead and tap up the live for me. Tap up the live. Share the live as well. Let's try to share it to at least 2 persons. That would be nice. Get more persons over here to come and enjoy the fun. All right, with studying. It's the fun. That's just weird. I have no clue why. I don't know. I honestly can't tell you. I don't know what's causing it because I turn off the fan and it's still doing the same thing. Yeah, I don't know why it's doing that. All right. So we talk about that one. This is your loop diuretic. Your spironolactone is which one again? And you have your thiazide diuretic here. Your spironolactone, who had said that one? Your potassium sparing, yes. All right, definitely. All right. So a patient with interstitial nephritis is most likely to have which history? A, recent antibiotic or NSAID use. B, prior kidney stones only. C, diabetes only. Or D, prostatic hypertrophy. So a patient with interstitial nephritis is most likely to have which history? A, recent antibiotic or NSAID use. B, prior kidney stones only. D, C, diabetes only. Or D, prostatic hypertrophy. All right, so let's see, A, B. All right, so the recent antibiotic use. All right. So we have your recent antibiotic or NSAID use. Drug-induced interstitial nephritis commonly follows antibiotics or NSAID use. All right, so let's go back to it. Interstitial nephritis is most likely to have which history? A recent antibiotic or NSAID use. All right, it's usually drug-induced. Nursing renal ABG study. Vote on potassium question. I have no nephrotoxic. Yes, it would be. All right. Okay, guys. Alexis is asking for where can she get practice for med search questions ATI style? Anyone know? The chat is too easy for her. So I don't know if you guys can help her to find one of those chats that will get her something a little bit more complicated. All right. So Quizlet, Alexis Quizlet is somewhere there sending you. All right. All right. Okay. So let's get to this one. Which lab findings suggest nephrotic syndrome rather than nephritic syndrome? A, massive proteinuria and hyperlipidemia. B, hematuria with red blood cell cast. C, oliguria and hypertension. D, mild proteinuria and azotemia. So which lab findings suggest nephrotic syndrome rather than nephritic syndrome? All right, so I see A. All right, massive proteinuria and hyperlipidemia. All right. So nephrotic syndrome is characterized by heavy proteinuria, hypoalbuminemia, edema, and hyperlipidemia. All right, for your nephrotic syndrome, you tend to have mild proteinuria. All right, a lot of times you will have hematuria, which is like your microscopic, or it can be gross hematuria. But sometimes we'll have periorbital edema. The blood pressure is often elevated. Albumin is usually normal or slightly low. And cholesterol is usually normal. And that's for your nephritic syndrome. All right. And they are the ones that has the Coca-Cola color urine. All right. What is going to be happening with the nephrotic syndrome patient and their urine? What is going to be the appearance for their urine? So nephrotic syndrome patients tend to have the Coca-Cola color urine. What is the appearance for your nephrotic syndrome patients? Cloudy, okay. So it tends to look a little foamy, frothy, definitely. All right, yes, Mel. All right, nice. So natural, I think you're saying the Coca-Cola color, that would be for the nephritic syndrome. All right, their urine normally looks like, you know, like Pepsi color. But for your nephrotic syndrome, the patient's color urine is foamy or cloudy, if you want to say. Mm-hmm. All right. All right. Oh, yeah, let's tap up a little bit more. Any questions so far? Megan, welcome, welcome. Okay, I am doing good. I'm doing good. How about you? And if you haven't followed us yet, I would love for you to go ahead and follow my page. All right, as I say, this is not like a ton of NCLEX type question. My page is to try and get us to think a little bit out of the box and be a little bit more interactive, study broadly, and just get as much information as we can from the questions we have here. All right. So just make sure you study before you come to class. Because it's not always going to be, you know, multiple choice question. All right. It's not always going to be multiple choice question. But I'll try to do them by system. All right. And then we brainstorm as we go along. Nice. All right. So patient, oh, we already know this one. A patient with acute kidney injury has a potassium 6.8. What's the priority here for this patient? We want to get the potassium lower, definitely. Yes, so you want to make sure you put the patient on the cardiac monitor, stabilize the heart and all. We do the cocktail: insulin, calcium gluconate, you know, dextrose, and EKG monitoring. All right, so place the patient on the monitor. Hyperkalemia can cause fatal ventricular dysrhythmias. You want to do continuous cardiac monitoring. That is the first intervention for this patient. All right. Yes, Labelle, Lola, you definitely want to do your insulin, calcium gluconate, marshmallow. Yeah. All right. Metallic taste in chronic kidney disease is caused by what? Why do we have our patients in chronic kidney disease saying that they have a metallic taste? What is it caused by? Where do they get that metallic taste? Carousel, accumulation of waste product. Anemia, no, it's gonna be like the built-up of like your uremia. All right, so the patient is actually uremic, so they tend to have that metallic taste. All right, so they're not able to excrete anything. So uremic toxins irritate mucous membranes. A lot of times they have the metallic taste and the ammonia breath. All right, so they have the ammonia breath. The stuff the kidney is going to filter, yes. All right, so the body's not able to excrete, so you're going to have all of that toxin building up. And so, you know, the patient just end up start having that taste in their mouth. All right. What's a normal creatinine level? What's a normal creatinine level? Oh, Lord. All right, 0.6 to 1.2. Nice. Okay. Less than 1.3. So you're 0.6 to 1.3. Definitely 1.2. All right. So that's the best indicator of your kidney function. Chronic kidney patient, disease patient, Should avoid foods such as, what are some foods that you'll encourage these patients to avoid? So you have your patients with kidney disease, processed high sodium, potassium, nice. Salt, high potassium steak, salty fries, definitely. All right, like your bananas and all of those things. Encourage them to avoid those. All right, bananas are high in potassium. It's very dangerous, or anything that is high in potassium. All right. Peritoneal dialysis with cloudy outflow. What are you thinking? What's happening here? Infection, nice. All right, yes. Hi, TS. Welcome, welcome. How are you doing? Yes, girl. All right, so you have a peritoneal infection, peritonitis taking place. All right. Hi, Jinju. Thank you for that gift, TS. So cloudy effluent is the number one sign of infection. All right. So you have a patient that is on dialysis or peritoneal dialysis. They start having any form of cloudy output. You definitely make sure that you take the necessary action. I'm doing good. I'm doing well. I'm doing well. Thank you. Thank you. Thank you. Thank you. What's the best indicator of kidney function? What's the best indicator of rigid board-like abdomen, fever, and cloudy? Definitely, Claude, you want to take them to the OR for that. BUN and creatinine. BUN and creatinine are the best indicator of kidney function. But if you're supposed to choose one, which one would you choose? Okay, if it says creatinine, all right. So your creatinine is more specific than your BUN. A lot of times if you have the patient like, dehydrated, then sometimes your BUN can be abnormal because of that as well. But any slight change in your creatinine, just make sure you're keeping an eye on that. Glomerulonephritis with cola-colored urine means. So you have glomerulonephritis with a patient with glomerulonephritis with cola-colored urine. What does that indicate? What's going on? Blood. Nice. J. Hematuria. Red blood cells bleeding. So blood plus protein, usually there's leakage, which makes the urine dark. Yes. It's something that is expected for your glomerulonephritis patients, all right? Hemodialysis effectiveness. How will you know that your hemodialysis is effective? What will you be monitoring, or what would have changed? Labs. Level of consciousness. Not looking for that. Why do we emergently take them to get their dialysis done? So we get them dialyzed because, okay, so Ian, nice, your potassium. So your potassium, the toxic built up, yes, all of those toxins. So your potassium especially is gonna be lowered. So that is gonna be able to tell you that your hemodialysis is effective, all right? Because a lot of times when they go in for dialysis, their potassium is very, very high. You get them for emergency dialysis, yes, so your potassium is one. So hemodialysis remove potassium on your waste, and once your electrolytes are, back to baseline normal, then you know that it is effective. Ipotane alpha treats what? What are anemia? Yes. Yes, anemia. Stimulates your red blood cell production. Claudiber. Nice. All right. So chronic kidney disease. Usually you have low erythropoietin production. All right. So usually you give this to help with treating it. Urethral kidney stone pain assessment finding. What in terms of the assessment finding, what are you expected for your patient with kidney stone? What are some things you can think of that you'll be having in terms of your expected finding? Rigid abdomen. Flank pain, nice. Will you be having urinary retention? Nice. Yes, so flank pain, dysuria, urinary retention, difficulty urinating, nausea, vomiting. But would you be having rigid abdomen? Is rigid abdomen something that is common for or seen a lot in kidney stone patients? Can't really know. Yeah. All right. The vomiting, definitely. So flank pain, usually radiating to the groin, is a classic renal colic pathway. All right. So a lot of times you'll find the patients holding on to one side. So they have the flank pain. That is a classic renal colic pathway for your patients there. Dark urine or concentrated urine, yes. What are some things you can avoid to prevent UTIs? So if you're teaching a patient, what are some things you can teach your patient to help with preventing UTI? Make sure that they're hydrating. Increase fluid intake, fluid hydration. Front to back clean, most importantly for your females. Take out Foley. Wipe front to back, clean front to back. You can talk about drinking cranberry juice. Any strong smelling, like, depending on the females, the underwear, try and avoid anything that has too much fragrance down that side. All right, bubble bath, things like those. All right, so bubble baths and all that you've said irritates urethra and promotes infection. So encourage them or teach them to avoid all of those. All right. Who this year? Urinate after. Douching. Oh Lord. Okay. After all right, you guys see it already. After kidney biopsy, what patient complaint indicates internal bleeding? We have your severe flank pain. All right. Binny, congratulations. Happy for you. So Binny passed her NCLEX, or he or she. Yeah. Congratulations, nurse. All right. So say you guys are gonna do well. So just continue studying. Continue studying, and that's just it. You understand? But as I say, you have to make sure that you read broad, study broad, and then you come to different, purses classes online and just answer questions. Get comfortable with answering certain questions. All right, and then from there. I'm from Montreal, Canada. Anyone writing the key? Okay. All right. So as we say, if you have a patient that went and did kidney biopsy, if the patient is complaining of any form of flank pain, usually that is indicative of internal bleeding. All right. What is the action of K-oxalate? A lot of times we tend to give it to our patients. So Stella says, I'm using NCLEX bootcamp to answer question. My Archer review is expired. Okay. Yeah, I look online for those, and the cost for the review courses, they're so expensive. You know, those subscriptions, they're so expensive. So in the meantime, I will try to get questions prepared and we just talk about them. All right. Yes, so K-oxalate, it lowers potassium. How does it lower your potassium though? Too much. You're welcome, no problem. Kaplan University prep test is what I'm going to use. Okay, G, nice. For lower and protect your heart. Less than 3 for. Okay, so Tina, yes, by excretion. Is it through sweating, vomiting, peeing, pooping? Because it's due to excrete it through the poop. Thank you, Nai. Oh, iffy. All right, yes. All right. Oh, mademoiselle, so that's I say all right too much. Let's work on that. So it removes potassium through the stool, exchanges sodium for potassium in the gut. Dialysis patients should limit, I think we talked about this earlier. So dialysis patients should limit what? Fluid intake, potassium rich foods, salt, potassium, definitely. So they're at risk for fluid overload along with all the other things. So the fluids are very, very important. They need to reduce that because you want to limit, you know, the risk of fluid overload. Processed food, meats, and high protein. Your AV fistula assessment, what are some expected findings? So you have your patient that has a fistula. What are some expected findings for this patient? Nice. Your thrills, your bruits. And that indicates patency and proper blood flow. All right. So you definitely want to make sure you're feeling, checking. And we rinse that since night. Definitely. Oops, it's me. What lab will show that a patient is dehydrated? So if you're going through your lab work, what are some of the lab findings that would indicate that your patient is dehydrated? BUN, your bun. Sodium, BUN. Hematocrit. Also, yes. But the best indicator would be your the best indicator for you have your specific gravity as well, BUN under 20. All right, so your IBUN. So BUN rises when kidneys filter less due to low volume. Skin, creatinine, definitely. Oh, you never see it. Nephrotic syndrome hallmark lab finding. What is going to be that one? I think you probably saw it already. Proteinuria. You have your glomerular membrane becomes leaky, and then you have massive protein loss. So the patient tends to have proteinuria in your nephrotic syndrome. All right. Earliest sign of kidney impairment. What's that? What are some early signs of kidney impairment? Oliguria. Creatinine. The slightest change in your creatinine. Would oliguria be an early sign or a late sign? Hematuria, microalbuminuria. Is oliguria an early sign or a late sign? Early sign oliguria, late sign anuria. Late chronic kidney disease, Anton. Okay. So it will be one of those late sign. Alright, so you have your rising creatinine. That's the most sensitive indicator for your kidney impairment. So the slightest change in that, just make sure you're keeping an eye on it. And the uremic frost indicates so you have a patient and they have uremic frost. What is that indicating? Metallic taste, chronic kidney disease, end-stage renal disease. Diva Queen. Nice. All right. Urea crystals deposit on the skin in severe uremia. Now, some of these we already talked about them earlier. The metallic taste is because of the same uremia built up. What are some of the reasons why you have pre-renal acute injury? The cause. What are some causes for pre-renal acute kidney injury? Dehydration, hypoperfusion, CCF, surgery shock, hypovolemia. All right. And just look at it. The pre, you're going to have pre, then you have intra and post-renal. Severe drop in blood pressure to kidney, hypoperfusion, uncontrolled hypertension, reduced cardiac output. Nice, all right. So low perfusion in hypotension lead to decreased kidney function. So pre-renal, all right. Whole metformin before a contrast because of so you hold it 48 to 72 hours because of the risk for lactic acidosis. Nice. Lactic acidosis, yes. So it increases the risk of metformin accumulation. What is the best fluid for kidney stones? What's the best fluid for kidney stone? Sulfur water. Okay. So hydration. Water is the answer to everything. Normal saline to be safe. Yeah, so always make sure you know, the fluids. Isotonic fluid is fine. Dextrose. No. G nice for what backup. Water is always the best, alright? Or you get the same concentration of the blood, which is the isotonic saline. But always encourage a lot of fluids. Early sign of pyelonephritis. Your flank pain. Nice. Cloudy urine. Fever. Dysuria. Yes. You will have a CVA tenderness, flank pain, kidney inflammation. All right. Whenever you have your patient with that kind of tenderness. Confusion post-dialysis usually suggests what? So after the patient had dialysis and they're confused, what is this suggestive of? Hypertension, low perfusion, dehydration, hypovolemia, hypertension for sure. So you have disequilibrium syndrome, so rapid removal of the solutes shifts fluid to the brain. So you tend to have confusion post-dialysis. That is because of this equilibrium here. All right, so disequilibrium syndrome is taking place where you have rapid removal of solutes fluid, shifts the fluid to the brain, and so the patient tends to become confused. And you'll have your hypotension, you know, hypovolemia, because of that rapid removal of that fluid. How do they treat this? You're thinking they probably give back the patient some more fluid? How would they treat this? If the electrolytes are yes, so your electrolytes are abnormal or imbalanced, so you want to go ahead and replace what electrolyte is abnormal. So you're gonna go ahead and try to give back fluids, all right? And then from there, so a lot of times, you know, they will tend to be very loopy. Try to get them to sleep a little bit. Sometimes they'll be reporting that, you know, they're dizzy and all of those. Just give them a few hours and usually they will, you know, bounce back. But you want to make sure you give them some fluid to kind of help with that blood pressure. When is your live days? So I'm doing Tuesdays and Thursdays. That's set in stone right now at 7 p.m. Central Standard Time. Working on other days except Friday. So Monday, Tuesday, Wednesday, and Thursday we're working with, all right? At 7 p.m. Central Standard Time. If you missed the live, definitely sign up on YouTube because all the live streams I've done so far are posted over there, so you can always check those out. All right. Good evening to you, John. Welcome, welcome, welcome. How are you doing? All right. Oh. Nephrotoxic drugs. What are some drugs that are nephrotoxic? They're bad for the kidneys. What are some medications or some drugs you can think of? NSAIDs, vancomycin, Tylenol, mycins, yes. IV contrast, retrovirals, Amphotericin. Yes. All right. So ibuprofen, your NSAIDs are pretty bad for the kidneys, along with all the others that you said here. All right, they reduce renal blood flow. So try and avoid the patients. Well, encourage your patient not to take these medications. And if you're going to be giving these medications, make sure you're looking at what lab value. What lab value is important for you to be monitoring. Creatinine. Creatinine is one lab value that you definitely want to keep an eye on. All right. What is an example of a renal friendly diet? If you have a patient that you're teaching about, their end stage renal disease, what is it that you would tell them that they should go ahead and eat in terms of their diet? Low sodium, low potassium, bland foods, poor souls, baked chicken, half peas. Oh Lord. No protein, low protein. So low sodium, all right, and all of what you said here. Cut down on their protein intake. So the low sodium helps to control their blood pressure and their fluid balance. They can't have protein just in moderate. They can have, yeah. So just a small amount, you have to encourage them to be consuming. You don't want to be having too much protein there. So that's why a lot of times when sometimes these patients realize that they have dialysis, they will eat whatever they feel like they want to eat. Don't even bother complain because you know that they're going to be going on dialysis the next day. So they just eat it just for the sake of eating it. They do listen, they do listen, but it's just that, just think of it. For the entire time you're getting dialysis, you have to be avoiding food. If you know that tomorrow you're gonna be going for dialysis, they just consume whatever it is that they want. They just eat and just enjoy it for that one day, because the next day they're gonna get it pulled off. So I don't really make it be a big deal. Make it be a big deal, honestly. I don't encourage it, but I totally understand, their little cravings at that time. And it just makes them a little bit happier. Because just imagine every day eating the same one bland diet. It not tastes good. Your mouth already have this metallic taste. And then to tell you that, oh, you need to cut down on this. Like, yeah, a lot of times they don't even have any appetite. So for that one day before their dialysis, eat as much as you can. And they'll tell you they'll have a lot of food on that day. And we talk about the expected finding after dialysis. They'll tend to have hypotension because, we remove so much fluid. So their volume is like low or depleted. So they tend to become hypotensive. So just make sure that they're lying down just to get that blood pressure back up, or you give them fluids just to bump it up. But usually in a few hours, they will bounce back in terms of their blood pressure. Their symptoms tend to be resolved. What is the normal urine specific gravity? I think we asked that already, but just in case we have new ones here. Like a small amount of fluids. Can do a small amount of normal saline. All right. Sometimes even 100 mils of normal saline pushes their blood pressure like very high. Yes, normal saline. A small amount of normal saline, 0.9 saline, usually helps with getting their blood pressure back up. Yes, 1005, 1030, less 7%. Normal specific gravity. Stellanique, what's that, less 7%? I always mix them. What are you talking about here? We kind of lost. What is it that you always mix? Does the NCLEX give labs? Does the NCLEX give labs, folks? As I say, you know, my little study session here is not only for NCLEX. All right. So at the end of the day, I wanted to make sure that you know the rationale behind certain things, and then from there, when you get into the working world, you know exactly what you're looking for on the lab results. So it's not only for NCLEX here we're studying. All right, so some person says yes, some person says no. They give some. So, oh, I was confusing the question with the A1C. Initially, I was wondering, because I saw the percentage, I was wondering, are you talking about A1C? But I'm like, I don't recall talking about diabetes here. So it should be less than 7. That's what you're talking about? Okay, no problem, Jay. Oh, gee, nice. That's me exactly. That's me. I have to try and understand what the labs are saying and try to put it in the pathophase and try, you know, just try to feel smart. Yeah. Even yesterday I did the same mistake. You're fine. Eventually you'll get it. So we say 10, 1.005 to 1.030. This usually reflects concentration ability of the kidneys. And then, oh Lord, I thought I was finished. How much questions I have? I think I have about 5 more questions. That's all. How much page? How much question? Let's see. Oh my goodness, that's a lot. All right. All right, let's try to see what this is saying. What this is saying. So you have an ABG question here. So the pH 7.25, CO2 55, bicarb 24. So pH 7.25, CO2 of 55, bicarb of 24, respiratory acidosis. Because you have your low pH and your high CO2. What's your normal for your bicarb? (22 to 26). So this is normal. So you can just eliminate this and then focus on the other 2 to get your answer. Noise, 20. Some books say 28. Yeah, I see different reading. I know 22 to 26. That's the one I know. But 21, 28, like, you know. Because sometimes when you go into the hospital, you might see different reading based on what they're using. So as long as you're close to that same range, should be good. But just make sure you know which one you're using for the exam if they're using anything specific. pH of 7.5 and a CO2 of 30. Respiratory alkalosis. Let's just hurry and do these. So high pH and a low CO2. pH of 7.3 with a bicarb of 18. Let's see, someone says respiratory. Remember, this is the HCO3, all right? This is HCO3, not CO2. So metabolic acidosis. Metabolic acidosis, not respiratory. So you have your low bicarb. And this is acidotic, so it's going to be a metabolic acidosis problem here. Welcome, Hapthon, welcome. So CO3, bicarbonate. You have your bicarbonate, you have your pH here. Thank you, Trish, for liking up the live. Welcome. It's been a while. So, okay. Metabolic alkalosis. Nice. So you have your high bicarb, increases in your pH. So you have your metabolic alkalosis. What ABG pattern is seen in DKA? Metabolic acidosis, so low pH, metabolic acidosis, so you will have your low pH and low bicarbonate. So your ketones are acids, so the patient is going to be acidotic, and then the kidneys are giving problems, so it's going to be a metabolic problem. If it's compensating, it's going to be a respiratory compensation. For COPD exacerbation, the ABG imbalance you'll have is Reggae Roots. Thank you for liking up the live, and thank you guys so much for tuning in. All right. Thank you guys so much for tuning in. Respiratory alkalosis. Okay. So you will have your respiratory acidosis, because remember you have your retention. You have your retention, CO2 retention. So no metabolic, it's not the kidneys. So it is respiratory acidosis. So you have CO2 retention taking place. So the buildup of that acid there is going to make the patient acidotic. And which system is being affected? Who had said respiratory acidosis? Kapoor had said respiratory acidosis. So when it's bicarb, it's the kidney. So yes, when it is bicarb, HCO3 is gonna be the kidney, and if the kidney is being affected, the system that takes over is gonna be your respiratory. So you'll have a respiratory compensation. If you have CO2, that is your respiratory system. If that one is the one that is affected, then you'll have a kidney problem. You're gonna have a kidney compensation. So CO2 respiration might mean acidosis or alkalosis. Yes. But if you know that CO2 is an acid, it's going to be an acidosis problem. All right. Not a problem. Vomiting causes which ABG imbalance? Metabolic acidosis, J. Loy. Acidosis or alkalosis? Alkalosis. So it's going to be a metabolic problem, but it's an alkalosis problem. Metabolic alkalosis. So you're losing all of that gastric acid. All right, diarrhea. Diarrhea causes what? What acid-base imbalance? Is diarrhea acidosis? Okay. So you have your metabolic acidosis because you're losing your bicarbonate there. All right, so with your diarrhea and your vomiting, so your vomiting is going to be your metabolic alkalosis because you lose your gastric acid, and your diarrhea is going to be your metabolic acidosis because you're losing your bicarbonate. All right. A patient that is in a panic attack, what ABG imbalance you have for that person? So they're hyperventilating, respiratory acidosis. Respiratory alkalosis. So the patient is hyperventilating. So you will have your alkalosis, your respiratory alkalosis, because of the hyperventilation, they're blowing off CO2. So they're blowing off CO2, so they're going to be in respiratory alkalosis. Gee, nice. Yes, you are. They're in respiratory alkalosis. I think we're almost at the end. What time is it? Kidney failure causes which imbalance, ABG imbalance? Nurse Malika. So yes, you can subscribe to my YouTube page at ThinkNursing. All the live streams are posted over there. So it's ThinkNursing, one word. It's posted over by that page on YouTube. Mansur is saying, can you be my tutor for LPN? Sure. Definitely. Not a problem, Nurse Malika. So this patient is gonna be metabolic acidosis, Angel. Nice. Because the kidneys can't excrete the acid. So you're gonna have that build up. So the patient is gonna be acidotic. It's gonna be a metabolic problem. A pH of 7.18 means acidosis. Yeah. That is life-threatening. So if you have a patient that is acidotic, if you have this patient that is so acidotic, how would you treat? What are you anticipating in terms of treatment for this patient? Your bicarbonate infusion, nice. All right. Patient that is compensating. Patient compensation for metabolic acidosis, what is that? Respiratory acidosis. So always look at the system that is affected, and then from there, you'll be able to tell what is compensating, because you're always going to be, it's either the lungs or the kidney. All right, so one of the two is, one is affected, the other is compensating. So the lungs is being is compensating here. So you have increased respiratory rate, so they're blowing off CO2 here. Oh, he didn't even say last question. I didn't even write that on. I think I started writing it another time. Yeah, so I think we did all the questions I had planned for tonight. Yeah, it takes a while to prepare the questions. So But, you know, nevertheless, we got it done. We got it done. But thank you guys so much for tuning in. Yeah, I am here still. I'm still here. Oh, I'm still here. Oh, let me hide it. Yes, definitely. I'll see you guys tomorrow. I will see you guys tomorrow. Hello, hello, hello. I will see you guys tomorrow. Tomorrow is what? Wednesday. Oh yeah, I'll see you guys tomorrow. And then from there, but definitely go ahead and subscribe to my YouTube page at ThinkNursing. Follow me here on TikTok as well at ThinkNursing. And if you have any questions, feel free to reach out to me. I'm pretty good at answering your questions. If you're an international nurse or someone that is, you know, planning on moving to the States. Oh my word. I think it was because of the food that I was eating, you know. I didn't know you never plan to turn the camera on you. You know what I mean? Yeah. But feel free to go ahead and ask me any questions regarding, you know, moving to the States here. I do talk a lot about that as well. So if you have any questions that you need answered, I will definitely be here to answer them. How long tomorrow? You know, usually this is what, 2 hours? Yeah, usually it's a 1 hour. It's supposed to be 1 hour, you know, 1 hour for the live stream. But tomorrow is what, Wednesday? Yeah, we'll probably end up doing 2 hours tomorrow because I'm not working on Thursday, I think. Yeah, so I'm in the States, but I need help. Not a problem, G. Nice. Not a problem. How long tomorrow? Same time? Around the same time. So anywhere between 7 o'clock and 7:30. If I finish working, you know, in time and get home, then definitely it will be 7 o'clock. But anywhere between 7 o'clock and 7:30 is the time period that I will be on the live. Because I have another live to go on to after. All right, and then from there. So, yeah. Need to go back and read again. BB. Okay, no problem. As I say, make sure you're taking the time out to read on your own and understand the content. And then you can come to these little, you know, little class and enjoy just persons just asking random questions, all right, in preparation for your exam. Because there is no set of questions that are out there that persons actually get from, you know, the NCLEX itself. All of those are questions that are similar to, you know, persons come up with and be using them. I know for UWorld and some other study material, I think some of those folks, they sit on the board that helps with creating those questions. So they will definitely have a better idea. All right, but as I say, I was thinking about getting it, but it's like super expensive. So not until I have a subscription going. You know them way there? So make hay while the sun shine. Take advantage of the free classes. Because if I do go ahead and get UWorld, as I said, the subscription is so expensive. All right, it's so expensive. So if I end up purchasing it, yeah, it's going to be a case where we're going to do a lot more, or I'll be doing a lot more with it. So definitely go ahead and do that. Okay, no problem, Lucy. Not a problem. I couldn't find what you taught yesterday. I was checking on your YouTube handles. So yesterday I did, what did I do yesterday? Oh, it was a mix. We did a little bit of a mix on questions yesterday. So if you look, there is a playlist. It takes a while before, so you have a playlist and then labeled it NCLEX live stream. So the one that I did yesterday, oh, you know what was happening? It was still loading for some strange reason. But just make sure all of them, just make sure you go in and you'll find it there. So 23 hours ago. So this one, yeah. So NCLEX, it's called NCLEX Nursing Study Mix. So it's there. It's just not in the folder as yet. So let me put it in the folder. But I try to put all of them in the folder for the NCLEX. So it's a little bit easier for you to just go ahead and play through. And then from there, if I get Kaplan, I'll share also. G, nice. Okay, nice. Yes, the YouTube handle is ThinkNursing. ThinkNursing. It's one word, so it's the same as my handle here on TikTok. So go ahead and subscribe to the page. Megan, not a problem, not a problem. Go ahead and subscribe to the page and check out the videos. Yes, it's $139 per month. That's for which one of them? Is that a Kaplan? All right, so let me put that in the folder. And I'm going to try to get all of them in the folder. Study session. All live streams. NCLEX. Yeah, it's just that it's a little bit time consuming. So I have to find some time and just make sure I do all of that. All right, and then from there. Can you do the CNA course? I have a book. I don't remember how I ended up with that book. But I think it's for the LPN. This one. We can always just run through. I can probably dedicate a day. One of my live stream. This is This is the one. Oh, probably I can't show it on TikTok because TikTok is weird. But if you go over to YouTube, you will see it over by YouTube. TikTok will tell me not to be promoting anything because it's not a live for, I guess, one of those, that you're promoting or selling things. UWorld. Okay, yes, for UWorld, that's the one I was looking on. Nursing study renal. Okay, so. But definitely, I can do some questions on that. But as I say, I have this book. I don't even remember how I ended up purchasing it. And I started going through it. It's not that bad. So unless you have a specific textbook that you guys use for the CNA program, you can always go ahead and let me know. And I'll take a look at it. But for now, it's more like just questions and answer. We try to just discuss it. So this one is Hartman Nursing. Let me quickly put it up. So it's Hartman Nursing Assistant Care, the basic. So I don't know if that's the one that you have. Yeah, so but we can actually try to do a day where we can look at some questions. So just in case persons have. Because as I said, the questions are not going to be that hard for both, the NCLEX and the other exams. Just make sure you're thinking about safety at all times, protecting the patient, protecting yourself. And that's it. NCLEX just want to know that you're practicing safely. You're thinking about the safety of the patient. And then from there. Yes, Mademoiselle G, nice. So just make sure you're reading broadly. And that's the most important thing. It's the medication that's going to mess me up. And don't think of the newer medications. Study the medications based on the classification of the medication. Know what the action is. And if that medication or if that class of drug does have anything to do with vital signs and labs, make sure you know those medications or the classification for the medications. Yes, there's a lot of them. But make sure you study the classifications and don't look at the individual drug. Because they're not going to be asking about the individual drug like that. Know what medications causes nephrotoxicity. Know what medication causes auto or the classifications. Things like those. And then from there, as I say, when you're going, it's all about critical thinking and safety. That is it. So they want to know that if you're going to be given a beta blocker, what is it that you need to do? You need to check your heart rate. You understand? They want to know that you're going to do that. So they're not going to ask about the latest medications that are out there. Having internet issues, miss most of the live. Arlene Henry, make sure you check out the YouTube page. You'll find it over there. All right. You'll definitely find it over there. But I will be here. I'll be here. We will go through questions over, questions. Just tell your friends about the page. Have them come over, hang out. And then from there. But as I say, later on, I will think about doing the subscription for the UWorld. The UWorld, but I don't want to be spending so much money. I'm doing a ton of subscription on so many things for my YT page. 3/4 of them I'm not using. I'm not using it because I'm not that tech savvy as yet. and I'm still working on organizing and everything. So yeah, I'll work on certain things, and then from there we will get the URL for later on. But by the time that you guys will be done with the exam pass and working as a nurse, I'm probably passing through answering 1 and 2 questions with other new students. I like questions and answers with rational explanation. Yeah, that's me too. That's me. That's why you see me asking the same thing, like, okay, then why you do this? You know, because at the end of the day, other persons are out there wanting to hear. And if everybody can come together and just pull their, you know, their little memory, their brain, and say, okay, then this is what is happening, at least you can see who is, you know, how we're thinking. And that's what I like about the study session we have here. What's the best way to pass NCLEX? The best way to pass NCLEX, I would say study broad. Then at the end, you can always go ahead and use your review course. So you definitely need to get like questions that are similar to your NCLEX exam, because you want to look at how they structure the question. You want to look at how they structure the question, the keywords that they're using when they talk about the first, delegate, priority, next. Those simple little things, that is what is making persons fail the exam. What is the best? So look at how they rationalize or how they ask the question, and then look at how they answer the question. And then from there, if you can see how they're doing that, then you will be fine. The keywords are the most important thing in the exam. So you have to study and understand the content itself. And after you understand the content, then you can go on to looking at how different persons are studying. And you look at the question itself and see, oh, that's the best, next, whatever. Use the process of elimination. You use the process of elimination. You use your ADPI, the nursing process. Always start off with assessment. If you're in a situation and you're not so sure, okay, then what do I do for this patient? Think about like the worst possible thing that can happen because of what medication or what is happening with the patient. Then you look at safety. Safety is always going to be top priority. Then you look at whether or not the patient is confused, and then you always change the algorithm. You know, if it is not safety, it must be something to do with respiratory system. Just look at the question and see what it is asking, and then from there you answer. But always think about your nursing process. Assessment, diagnosis, planning, implementation, evaluation. Once you use that, you're good to go. Always look at Maslow's hierarchy of need. All right. Always look at airway, breathing, and circulation. And if every time you have a question and you're saying, okay, then is this an ABC question? If it's not an ABC question, move on. Is this a safety question? You look at Maslow's hierarchy of need. If it's not a Maslow's, you move on. Is this a nursing process question? And then from there. But it's always going to be one of the three. All right. And then from there, you will get your answer. ABCs, ABCs, ABCs. All right. So that's the only thing I can say. Just study broad. Don't limit yourself to, the question itself. Understand your pathophysiology. Study your high yield questions. So you have certain things that are gonna be on the exam. There's no way you're gonna be leaving the exam and not getting like a example or a question that is related to you checking vital signs. There's not gonna be a question that there's not gonna be a exam that you'll do for your NCLEX and you don't get something regarding a lab finding, because they want to know that you're thinking outside of the box for certain things. All right. You're gonna get your medication question. You're gonna get a side question. There is gonna be one. So if you feel as though you're passing through and you don't find it, yeah, it's eventually gonna come. So make sure you focus on your GI, your renal, respiratory, cardiovascular, neuro. Those are the major parts of your exam. Once you understand that, then you can think about the other parts, because 1 and 2, the question is gonna trickle in. All right. So when you look online, you will see they will kind of give you an idea. They will kind of give you an idea of what to look for in, like, say, for example, for a pediatric case. These are certain things that you will definitely get on the exam. Hi, nurse educator Amanda, welcome. So go ahead and focus on those, and then, you study on your pediatric, and then you move on to your mental health. They're not expecting you to know everything, but there are certain things that, you definitely need to know. All right. Not a problem, Megan. Sure, you can. As I say, I live stream at 7 p.m. Central Standard Time, Monday to Thursday. All right, so you definitely can come and join us. I'm using Quizlet app to study. Okay, that's fine. That's fine. Quizlet is pretty good. It's good to know the pH levels and normal levels to know when they're abnormal. Yes. So just know the different, lab values that are pretty common. And then from there, legal aspects, yes. All right, but as I say, you might get 1 and 2 questions, but the bulk of the questions are going to be on those 5 areas that I told you about, those systems. So get those systems under wraps. If you know that, as I say, focus on your lab values or focus on the medications that require you to do either some form of checking lab values or vital signs, things like those. Because as I say, at the end of the day, they want to know that you're thinking critically. They want to know that you're thinking safely, when you're administering certain things or doing certain things for your patient. So safety is always going to be key. And from there, you just keep your fingers crossed and continue to go through. What systems are those? So GI, you talk about cardiovascular, respiratory, neuro, and so GI, cardiovascular, renal. Is renal? What are the 5 areas? So you have cardiovascular, GI, respiratory, neuro, and renal. Yeah, so once you focus on those, the other areas, you'll definitely get little questions from them, but it's not going to be like the bulk of the exam. But look online and you will see the percentage that, each section carries, the weight. And then from there, that will kind of give you an idea of the emphasis you need to place on each area. All right. Menamin, welcome, welcome, welcome. How are you? All right, so Gabriel, welcome, welcome. Reggae Roots, it's Gel. All right, so I am gonna go now. It's way past my bedtime. I still have about 5 charts to complete. Need to complete them before I go to my bed because I don't want to bring them over for tomorrow. And then from there, all right, so do enjoy your evening. And thank you guys as usual for showing up. Remember to go ahead and claim your points on your heart knees here. All right, it doesn't make sense to sit down and watch the live and don't claim your points because I can't do anything about your points up there. All right, especially if you're making content, you definitely need to do that. All right, so enjoy your evening now, guys. It's 9:25 for me. I'm gonna go and finish up my evening. All right, remember to go ahead and subscribe to my YouTube page. I think nursing, and what else? Follow, share, tell your friends about it. And even if they're not nurses, they can still come over or even join me on my YouTube page because my YouTube page talk about everything. If you want to know my background, yeah, man, go over there and you sit down and listen and laugh at my stories about growing up in Jamaica. Oh, yeah, I'm from Jamaica, so definitely as well, go ahead and follow, or you follow me already. So go ahead and support my GoFundMe page, all right? Go ahead and support my GoFundMe page. But if you don't want to support it, I totally understand. There is our supportjamaica.gov.jm page that is accepting donation on behalf of our Melissa victims. So go ahead and look up that website and donate. All right. Oh, I did sign up for volunteer services to go back to Jamaica and start working. So I heard from the folks today. Oh, I think I'm supposed to be getting back another email, hopefully soon. Some persons were responding about wage and all of those things, but it's volunteer service. So I don't know. Sometimes when you have the army go out to different places or they send persons, you have some companies that are for profit and you have some that are non-profit. So it depends on which one you're with. Some will do pay you because you still have your bills and all. Some, if it's not for profit, then they will just go ahead and get you into the island and you help out with how you see it fit, but you're not getting paid. So I signed up. I'm waiting to hear from the folks, and then from there, let's see how that goes. All right, I'm gonna have to probably adjust my work schedule to probably try and, I don't know, And then from there, if my boss allows it, because then that would be what I'll have 3 days plus the weekend. I probably could push not working on a Monday, Tuesday, Wednesday, and do work on a Wednesday, Thursday, Friday. So that way I'll have what? Thursday, Friday, Saturday, Sunday, Monday, Tuesday, Wednesday. So I'll have 7 days. 7 days better than none, not true. Yeah, man. So we'll see how that goes and then come back for work. Next week I will be going to St. Elizabeth. That is part of our region to volunteer. Okay, Arlene. Where are you now, Arlene? Oh, about person that's not a nurse and in the state but going home and wanted to volunteer. So if you, okay, so that's a good thing. So if you are not a nurse and in the States and you're going home and wanted to volunteer, definitely, because that company is a not-for-profit. So if you're able to do that, the company is called medical missions. So if you're overseas and you want to do that, medical missions, let me tell you, medical professionals on a mission. All right, that's the name. And they will help with, they do help with, you know, traveling, getting you to the country and back based on what the email says. They help with traveling, airfare. They also help with accommodation. They help with food. But the only thing is that they're not going to be paying you anything. So we'll follow up with flight options, lodging, a safety brief, packing list, and on-the-ground partners once teams are set. All right, so that's what they help with. So getting you into the country. And then from there, if you're a nurse in the States here, you can go in as clinical care, logistic distribution, community outreach, coordination. Those are the preferred area or the scope that they're looking for persons. So you can decide where you want to go. As I say, it's not something you're going to be paid for because this company is not for profit. So they don't have any money to give you. All right. They don't have any money to give you. So if you want to go down and, you know, do your service, just sign up with them and they will coordinate with the other folks in the area that is doing all of these logistics, community outreach. They will be able to match you with whatever area you want to go in with. And then from there, if you're a nurse, it's the same thing. If you're a nurse in the US here, and if you're a nurse in Jamaica, or you are a nurse in Jamaica, then there is another flyer I got that I said I was going to post it on my page, slipped me today, where you can actually sign up with that company. And what they do is like they help with getting you license. So when you get to the States, when you get to Jamaica, then it's a little bit easier for you. So when you go down there, it's the same not for profit. So you just get your license. So when you get down there, if you want to go to, say for example, Mandeville Regional to help out with, you know, nursing duties, then you already have an active nursing license. You can just go and probably say, hey, because they already would be aware that you are from the States and you're here for voluntary service. So it's just helping you with getting that going, but you're not going to get paid because most of these are not for profit. My sister-in-law is from Jamaica. Okay, nice. They're not for profit. If you find one that is for profit, then there is highly, you know, a chance of them paying you while you're there, especially if you're going to be there for probably like 1 month, 2 months. Like, unless you're rich, you know, you can go down there and spend 2 months doing all of that. But a lot of persons will be going down thinking that they'll be paid. But it depends on whether or not if you're with a for-profit or a non-profit, you know, organization that is doing the volunteer service. All right. Southern Regional. Okay. Yeah, that's where I used to work. I used to work at Mandeville. So the ones that will help you with getting your license ready in Jamaica is this one. So it's Healthcare Hands Across Jamaica. All right. So they're the ones that you will send out your information to, and they will tell you how to go about with getting your license activated or reactivated. So when you get into Jamaica on your regular visit and you feel as though you have 2 days that you just want to go and spend with, you know, folks in Westmoreland, then you can always say, hey, they can make the necessary call and get you started immediately because you would have already been prepped in terms of your license. All right, so that's just it. So those are the only things I've gotten so far regarding that. All right, but I would love to go down But I have to think about how this thing will work out first. You understand? You understand? So that's just it. All right. So I only have a certified. I'm certified. As I say, God's blessed twins. It's, you know, even if you have that, that's fine, because you can go in. They need persons to help out with probably getting into communities to help out with handing out packages, things like those. So you don't have to get like CPR certified, AED certified, nothing like that. You just need to be there healthy, and you can walk and talk and do one and two things. All right, so they need persons to help with distributing items. So if that's what you're able to do, then definitely. If you're a nurse, then, you know, you'd want to probably go in that area and help out, relieve some of the burden of the other nurses that are there, because I'm sure they're under stress right now. Them body tired. I understand. I know it's, you know, yeah, I know it's gonna be tiring for a lot of them, because when I was there, it was. You understand? Because a lot of times we never really have much resources. We were always short staffed. And so right now, that's why I'm encouraging nurses that have left Jamaica to say, yes, I know. You know, let's just forget about that and just go down there and give back a day or two, 1 week or 2 weeks, in helping out as much as we possibly can. So that's just it. All right. Well, until then, I will take my leave. I'm gonna go now. All right. My little boy is here. I don't know why I don't want to go to embed him there on the floor, looking up at me. But anyways, I will go now. All right. I will see you guys tomorrow. And thank you guys again for tuning in. All right. Enjoy your day, Arlene, and stay safe, along with everyone else. But, you know, because Arlene is from Jamaica, and Arlene is going to go down to giving her the extra blessing. All right. All right, then. Bye, guys. You're welcome. And for you guys, thank you so much for tuning in. All right. I'm trying to get this thing fixed properly, where, you know, the computer is facing that side. Well, the phone is facing the computer. Trying to get it set up a little bit. I'm pretty new to not YouTube, but with the live being projected on the computer. So I'm working on that. Until then, it's going to be a little bit chaotic. It still look a little bit chaotic. All right, but otherwise, the information is there, and that's the most important thing. All right. But I'm going to go now. All right. It was nice talking with you guys. I don't know who exactly is here. Megan Dagan Hart. I don't know if you're here, and I don't know if Miss Patsy is here. I just have a feeling that Miss Patsy is here. Because she's always on the live. But, you know, sometimes you have some persons who don't know anything about, you know, when they're on the live, what they're supposed to do to make themselves be known. And they don't want to type in or do anything. Yeah. So I have some relatives that are like that, but they will show up for the live. And they don't say a word. And then me thinking that I'm not getting the support. Because that's how I feel sometimes. I feel as though family members, they don't, you know, they're the last person to support you sometimes on these things, because I guess because I'm already know you, so they don't show up. Don't show up. You'll be on the live and zero person on the live. And you send the live to them, you know. You send them the live and say, hey, I'm doing a TikTok live, and not one of them show up. Because I'm like, oh, I already know what you're going to talk about. Or I can't hear you in the house. No. But anyways, I appreciate them, because they're the same ones that say, keep on going. You know, I tell my friends about it, but they're not watching it. All right. Anyways, I'm going to go now. All right. Bye.